real pleasure to welcome you to this laboratory demonstration. This is something we're doing on behalf of the World Federation of Haemophilia, in particular on behalf of the Laboratory Sciences Committee. Chair of the committee at the moment, Dr. Sukesh Nair, he's had an important input into this effort, even though it's me that's making the laboratory demonstration today. My name's Steve Kitchen, I'm a laboratory scientist from the Sheffield Haemophilia Centre. We're going to be discussing one-stage factor VIII assays, and before we start on that, I just want to remind ourselves that the techniques we'll be talking about and the demonstration we'll be doing is all described in the World Federation of Haemophilia Laboratory Manual. I'm very pleased that WFH have made this laboratory manual available free of charge. It's on the website, I think you know the website, www.wfh.org. There's a substantial publications section on the website, and one of those areas includes diagnosis, and the laboratory manual is available on that location. It's possible to download the whole manual as a single document, but we absolutely recognise that people will be interested in different parts of the document, and so we made it possible for different sections to be individually downloaded. WFH, of course, is an international organisation, and so absolutely recognises the importance of having documents available in different languages. So I'm also very pleased that the sections and the manual are available in Spanish translation, in French, Arabic, Russian, Chinese, all available through the website. So again, the techniques that we'll be talking about, the principles, the discussion, all detailed in the laboratory manual. So we'll be discussing and demonstrating one-stage factor VIII assay. One-stage factor VIII, currently the most widely performed factor VIII assay in most countries. We may see some changes in the future as the extended half-life factor VIII products are increasingly coming to market. We may anticipate an increased use of other factor VIII assays, chromogenic assays in particular. But at the moment, at least, one stage is the most frequently used, and that's the technique we'll be demonstrating just now. So I think we should just remind ourselves first the principle of the one-stage assay. It's based on APTT and uses the same APTT reagents as are used for APTT determinations. So the starting point, if we think about a patient with factor VIII deficiency, I think you know that this causes a prolongation of APTT. The more severe the deficiency, the longer is the prolongation. So there is a relationship. And it's really that relationship that we use to construct a quantitative assay. If we have a plasma which is completely deficient in factor VIII, it will clot. I think you know that. The APTT depends on the reagent. Might be 100, 110 seconds with another reagent, 90, 100, maybe even a different reagent, 120, 130, but a grossly prolonged clotting time. In contrast, a normal sample containing a normal concentration of factor VIII, 25, 30 seconds. And we know that in between those two clotting times, the lower the level of factor VIII, the longer is the APTT. And so we make use of this fact. If we have a factor VIII deficient plasma then, completely lacking factor VIII, less than 1 international unit per deciliter. If we add some factor VIII to that factor VIII deficient plasma, the APTT will be shorter. The more factor VIII we add, the shorter will be the APTT. And so again, we can make use of this information to construct our one-stage assay. It means that one of the most important reagents in our one-stage factor VIII assay is the factor VIII deficient plasma. It's absolutely key, and there are a number of important features, and again these are described in the WFH laboratory manual. Well, the first and most important feature, it must completely lack factor VIII, so the level should be less than 1 international unit per deciliter. And for many years the most commonly used source of factor VIII deficient plasma was donations from patients with severe haemophilia. And this works very well. On the other hand, we're in an era now where an increasing number of patients are on prophylaxis, and that's a fantastic thing, of course. It means that there may not be so many patients who have got that, or spending the time where their factor VIII level is below 1 international units per decilitre, and again, that's a really good thing. We've also got ethical issues about using patient material, and of course there are also implications in relation to transfusion-linked viruses. So for many years now, the vast majority of factor VIII deficient plasmas have been prepared, started with pooled normal plasma, from which factor VIII is specifically removed. Can be done chemically, most often using antibodies, immunodepletion. This is currently the most frequent source. And what we should keep in mind is that sometimes in that process of removing factor VIII, that's the target, sometimes at the same time as an unwanted side effect, von Willebrand factor is also removed. So there are two types of factor VIII deficient plasma, those which are in addition lacking von Willebrand factor, and those which contain essentially normal concentrations of VWF. And I think there are some implications of that, particularly in relation to inhibitor assays, and that's something we're not discussing just now. That's a story for another day. In relation to diagnostic factor VIII assays or treatment monitoring, actually for the vast majority of samples, the results which we obtain, normal subjects, mild haemophilia, moderate, severe haemophilia, von Willebrand's disease, the majority of samples, actually we obtain very similar results irrespective of the level of VWF in the factor VIII deficient plasma which is being used. We know this from data in our proficiency testing surveys. Nevertheless, it's important to keep this in mind. The second important feature of our factor VIII deficient plasma, it should contain normal concentrations of all the other clotting factors. So factor VIII deficient plasma we're now discussing, no factor VIII, but should contain normal concentrations of the other clotting factors, those factors relevant to APTT. Remember, the test is based on APTT. So it needs to have normal concentrations of contact factors, 12, 11, and so on, factor 9, factor 10, factor 5, prothrombin, fibrinogen. These should be at normal levels. The absolute concentration is not so important as long as it's at least 50 international units per deciliter or a normal concentration of fibrinogen above, say, 1.5 to 2 grams per litre. And this is normally the case for the majority of commercial factor VIII deficient plasmas which is available. So a factor VIII deficient plasma, very long APTT. We want to add to it a series of different concentrations of factor VIII, and we're asking the question, what's the effect on the APTT on this factor VIII deficient plasma? The more factor VIII we add, the shorter is the APTT. And so we do this by starting with a calibration standard reference plasma. It carries different names. So the second important reagent is the reference or calibration plasma. Usually a pooled normal plasma, often freeze-dried, and that's fine. What's important is that this material should be calibrated against WHO international standards, either directly, for example, if it's calibrated directly against the current WHO plasma standard for factor VIII. More frequently it's done through an intermediary, and that's fine. More frequently it's done by calibration against the SSC, Science and Standardization Committee, ISTH, secondary standard. Most companies use this material. But the key is that that material is also itself calibrated against international standards. It means that we're calibrating in international units, and that's really important. So we begin with a commercial reference plasma like this. We buy that from a particular commercial company usually, and it comes with a labelled potency. A potency for factor VIII, and we should work only with materials calibrated in international units, and if a manufacturer doesn't do that, I don't think we should use that material. The majority of commercial standards are calibrated in this way. So we're going to use this to construct different concentrations of factor VIII. And we do that by dilution. The more we dilute, the lower is the concentration. We need to have a linear relationship between the APTT, which we perform on the deficient plasma, after we've added different concentrations of factor VIII. We need a linear relationship between the amount of factor VIII we're adding and the effect on APTT. And this is typically possible if we start with a calibration plasma in which the factor VIII is usually close to 100 international units per deciliter, if you prefer one international unit per mil. Sometimes it's a little different from this, usually it's a little different from this, but it's usually close to this for a pooled normal material. And for that type of standard, we frequently use dilutions beginning either at 1 in 5 or 1 in 10 dilution. We'll start today using a 1 in 10 dilution, and then we need to prepare even additional dilutions, more diluted, lower concentrations of factor VIII. So the first thing we're going to do with this material is to construct some dilutions. There are a number of studies which have looked at the use of different diluents to construct those dilutions and the calibration curve, different diluents. The majority of factor VIII assays currently are done using buffers like imidazole buffer, glaucylene buffer, like Auron's buffer, but crucially with a pH at 7.35. This is the most frequent material which is used, and it works extremely well for the majority of settings. There are some studies which have looked at the use of factor VIII deficient plasma even to construct those dilutions. Of course, that's got cost implications, and it may be particularly useful to do so if we're performing assays where the factor VIII level is particularly low. There is some evidence for that. At the moment, the majority of centres from surveys of practice are making all the dilutions in a buffer, and we'll be doing that today. We'll be using an Auron's buffer, pH 7.35. The tubes which we use, the receptacles we use to make these dilutions is important. We should use plastic tubes which we know will not interfere in clotting in relation to contact activation and so on. So we've got some plastic tubes to do this here. These are ones which we've used before in this assay. So this is a commercial reference plasma, and it has a labelled potency. The manufacturer assigns the potency against a WHO standard, sometimes against an intermediate, a secondary standard, which itself is calibrated back to the WHO standard. And that's really important. It means that the reference plasma has a value, a potency, described in international units per deciliter, usually close to 100, or if you prefer, 1 international unit per mil. What I think is really important is that we don't slip into the usage of the old terminology, percentage, and the reason for that is because the percentage system relates a test sample to pooled normal plasma, which has not been calibrated. And it's what we've noticed in a number of studies and publications. If you don't calibrate a pooled normal plasma, there is a highly variable factor VIII content. Even if you make a pool of the same 20, 30 normal subjects, the amount of factor VIII contained in that pool varies really quite dramatically from one pool to another. Can be over a twofold range, for example. Trevor Barcliffe and others have shown this in a number of studies. So it's really important that we use a standard which is calibrated in international units. And if we've done that, it's therefore important that we describe the results in international units. Otherwise, a person might assume that the test has been done really in percentage against pooled normal plasma, and that's not the case if the standard is calibrated in international units. So I think it's important not to be lazy in the terminology. We're going to be doing this demonstration using manual method in the water bath, even though we recognise, of course, the majority of factor VIII assays worldwide increasingly are performed on highly complex autoanalyzers, semi-automatic, fully automated systems. But I think it's important to keep in mind the principles of the test, and that's much more easily visualised and I think discussed using manual technique. I think it helps people to understand the problems, the issues, the limitations, if we can actually remind ourselves which components are working in which way, and that's much easier in the manual method. And I think we're also very fortunate in hemostasis that actually the results of a manual factor VIII assay in the water bath are perfectly acceptable for patient management purposes. That's unusual in laboratory tests, and many areas of laboratory testing, cell counting, clinical chemistry. It's I think true to say that, let's say, manual equivalents are so time-consuming and in particular are unacceptably inaccurate or imprecise that they can't be used for patient purposes. They're simply not safe. That's not the case for factor VIII assays. I think the method we're about to show is acceptably precise. It's perfectly usable for patient management purposes. And that's an advantage in a centre who's not able to put in place a complex autoanalyzer. So that's the other reason why we're also going to work in the water bath today. So we have the calibration plasma and some diluent. We'll be making 3 different dilutions, and then we'll generate some clotting times, and we'll discuss what we're doing as we go along. So we're going, for this particular reagent set that we're working with, I know from past experience that dilutions of 1 in 10, 1 in 20, 1 in 40, 1 in 80, 1 in 160, these kind of dilutions are appropriate for use in this assay. We'll make 3 dilutions of the standard to construct our initial standard curve, and so we'll begin with dilutions of 1 in 10, 1 in 20, 1 in 40. It's important that at least 2 of these dilutions are prepared independently. We should not make the first dilution and use this further diluted to construct the other 2. We shouldn't do that. It's bad practice, because if we make a pipetting error into the first dilution, we simply transfer that down the line of dilutions. So at least 2 of the 3 should be made independently. It's fine to make all 3 independently, but at least 2 should be independently made. So to make a 1 in 10, 1 in 20, 1 in 40, we're going to mix 100 microlitres plus 900, 1 in 10, 100 microlitres plus 1.9, 100 microlitres plus 3.9. So we'll make the 3 independently just now. So we need to pipette some buffer, 0.9, 1.9, and then 3.9. And in a moment we'll be diluting the reference material into each of these tubes. The tubes that we're using, it's important that we select tubes which have no impact on coagulation, and this is more likely if we use plastic than if we use glass. These tubes should not be reused. It's very difficult to clean plastic or glass tubes which have been used in this way, to clean them and reuse them for this type of work, because we noticed that even very small amounts of residual detergent used in cleaning can really have an important effect on the clotting times which we obtain. So it's a false economy. Those centres who have tried to do this cite the cost of disposables as the reason. I really think it's a false economy. It interferes with the precision and the accuracy of the test and introduces an important source of error. So I really don't think it's more economic. Okay. So we'll add now 100 microlitres to 0.9, 900, 1 in 10. 0.1 to 1.9, 0.1 to 3.9. 1 in 10, 1 in 20, 1 in 40. And each of these should be mixed. In a moment we'll be testing a quality control sample and some patient samples. we should not prepare those dilutions until just before we make the test. So we prepare the standard, make the test. Prepare the IQC, make the test, and so on. That way, the interval between preparation of dilutions and obtaining the clotting times is the same, and we should always be trying to treat the standard and the QC and patient samples in the same way. It's really important to do that. So we're going to run effectively some APTTs on this mixture. So we'll do that with glass tubes. Although the dilutions are in plastic, it's better to use glass tubes for the clotting times. You'll see that we get better mixing in the tube, and it's easier to visualize the clot. So I'm going to need 3 tubes in here for these 3 clotting times. This is our factor VIII deficient plasma. We need to be sure that all the factor VIII deficient plasma we'll need for this batch of work is ready and prepared and forms a single pool. So what do I mean? In this case, we have around 3 mils of factor VIII deficient plasma. Each of those was a single freeze-dried 1 mil vial. But I've prepared those and pooled the 3 vials. This way, if there is any small difference in the filling of those vials or in the reconstitution, it disappears when I make the mix. It's a single mix, and it will be the same then for each of these tests. It means that we have to complete work with this during a finite time period. If we complete this work over the next 2 hours, there won't be any change, any relevant change, any significant change that will impact on the results that we obtain. So we have to use this within its period of stability. So in each glass test tube, we need to add the same volume of factor VIII deficient plasma, 100 microliters. And this is then warming up to 37 degrees. It's important to check the temperature on the water bath. We should record this at each time of use. We want to be sure that the water bath is retaining its temperature. You can see we have a thermometer, and so this is checked and recorded on a daily basis and at the time of the testing. 0.1 of factor VIII deficient plasma. To the first tube, we're going to add the same volume, 0.1 of 1 in 10 dilution of standard. Goes in the first tube. It's simply warming up at the moment. There's no reactions occurring. Factor VIII deficient plasma, dilution of standard, 1 in 10, and in this next tube, 1 in 20. And in the third tube, 0.1, 1 in 40. So each tube contains the same volume of factor VIII deficient plasma, providing the same level of clotting factors in excess. The dilutions of the standard contain different concentrations of factor VIII, 1 in 10, 1 in 20, 1 in 40, different concentrations. So we've added different amounts of factor VIII to each of those tubes, and that will have a different impact on the APTT of the factor VIII deficient plasma. So whilst that's just warming, in a moment we'll be adding APTT reagent. The APTT reagent that's used can be the same as used for routine testing. We need to place a volume of this. It's sufficient for these assay into the water bath so it's coming up to temperature just whilst we're talking. At the end of the APTT, of course, we'll be recalcifying, we'll be clotting with calcium, so we also need a volume of calcium. The concentration of calcium should be the same as that used in APTT, and for the vast majority of reagents, 25 millimolar. It's a 1 in 40 dilution of a molar solution. There are some reagents which are used in combination with 20 millimolar, and again, if that's recommended by the manufacturer for use with that APTT reagent, that should also be the same here for a factor VIII assay. So these are simply warming up at the moment. Now, I mentioned the factor VIII deficient plasma. It's an expensive material in most parts of the world. It's acceptable to use plasma from a severe haemophilia patient provided several conditions are met. First of all, the ethics and ethical approval and informed consent process is absolutely essential. If that's in place and it's acceptable under those rules and regulations to do so, then it's possible to use a patient factor VIII deficient plasma. If so, then the patient should not be on prophylaxis. It can only be done for patients who are on on-demand therapy. It can only be done if the level of factor VIII is for sure less than 1 international unit per deciliter or less than 0.01 international units per mil. It has to be fully deficient in factor VIII. It's also important that there is no possibility of a factor VIII inhibitor present in that factor VIII deficient plasma. That's true for commercial materials as well, but if a patient has any history of a factor VIII inhibitor that then is not suitable for use in the assay, you'd get interference in the test. And there have been cases reported where a commercial factor VIII deficient plasma has been released for use in which the plasma was prepared by immunodepletion, an anti-factor VIII antibody used to remove the factor VIII, and during that preparation, some of that anti-factor VIII antibody has leaked away from the column that's been used and deposited in the factor VIII deficient plasma. That has happened. And of course, then that interferes with the clotting times and leads to completely inaccurate assays and absolutely should not be used. I think that's a very rare event. Okay, so in the tubes at the moment, factor VIII deficient plasma, 3 different dilutions of standard. We'll effectively be performing now an APTT on each mixture. So we've got the APTT reagent, activator, phospholipid. You know that there are many different activators present in APTT reagents, sometimes kaolin, sometimes ellagic acid, sometimes micronized silica. This can have an influence on the results. It's particularly important, or will have a particularly important effect in samples which contain some of the new extended half-life products which are coming through to market now and in the future. So I think this will be increasingly an important piece of information to be aware of in relation to APTT reagents. So we add APTT reagent to the first tube and mix. APTT reagent contains activator, contains phospholipid. At 15 seconds to the second tube and mix. At 30 seconds to the third tube and mix. So during this stage, APTT reagent, contact activation, 12 to 12A, 11 to 11A, practically no calcium present, so no further at the moment. The longer the activation period just now, the more 11A, the more 12A, the more 11A we generate. So this needs to be carefully timed. For this particular reagent, 3 minutes. For some others, 5, sometimes 10. But important to use the manufacturer's recommended activation time, and very important to carefully control this so that we've got the same activation in each tube, the same activation period, the same for patients, the same for QC materials. Different phospholipids present in the various reagents. For most samples, of course this will have some impact on the clotting time we obtain, but for most samples, when we convert clotting times into factor VIII activity, we'll see that shortly, then we obtain the same answer, irrespective of which APTT reagent is used. The vast majority of samples, normal subjects, most patients with von Willebrand's disease, haemophilia and so on. But of course there are different phospholipids in the reagent, so there is the potential for a different result. For example, if there are defects which impact on the way that factor VIII might bind to the phospholipid, for example. So there is a possibility of different results with different reagents. In my experience, it's not a common occurrence. At the end of the 3-minute activation, we'll be adding calcium, and this will allow the remaining reactions to occur, 9 to 9A, 10 to 10A, and so on. And of course, each of those mixtures contains a different amount of factor VIII. So the 10A generation and later the clotting time depends on, here, the level of factor VIII. It's factor VIII which limits the rate of 10A generation, limits the clotting time. So one depends on the other. That comes from the factor VIII deficient plasma providing all the other clotting factors in excess. So as we get to the 3 minutes, we add calcium to the tubes. And although I'm doing this just now for the purposes of demonstration with the 3 tubes having activation at the same time, it's not essential to do this. It's possible to complete the first tube, then do the second, then do the third. Scientifically, that's acceptable. This is a little faster. So at 15 seconds, second tube. And at 30 seconds, third tube. So now we need to observe these tubes for clot formation. And this involves, we've got a balance to pay attention to. We want to keep the temperature as close as we can to 37. We know that these reactions are temperature sensitive. Therefore, we want to keep the mixtures immersed in the water as much as possible. But at the same time, we want to observe the clot formation. And of course, it's important to try and do this accurately. This will have an impact on the results which we obtain. First tube's clotted. So we've got this balance between maintaining temperature and observing the clot. There is a recommended frequency of this tilting process. It should be 3 times every 5 seconds through 90 degrees. So 90 degrees to the horizontal and back. And that's more or less the frequency with which I'm now doing. 3 times every 5 seconds, 90 degrees. With the regular immersion, we're helping to maintain the temperature. Just waiting for the third one to clot. And it's now clotted. So we've got 3 different concentrations, 3 different clotting times. 63 seconds, 69 seconds, 85 seconds. Progressively longer clotting times. Why longer? Because the factor VIII is more diluted, lower concentration, so there's less and less factor VIII, therefore there are longer clotting times in each of the mixtures. It's useful to keep a record of a number of aspects of the assay that's being performed. And one way to do this is with a results sheet in this kind of format. And there are a number of pieces of information that I think it's important to record. We want to know the standard that's used, the deficient plasma. In particular, we want to record which lot numbers. Because if we see a change in some results or there's a question about any result, it's very useful to be able to trace back the results and see what happened. Was there a change when we moved from one lot number to another? In my experience, this is not normally the case. We've successfully moved from different lot numbers of APTT reagent, reference plasma, deficient plasma, and we don't see a difference in the results of our internal quality control. That's unusual. But this allows us to keep track of that information. So that's recorded on this sheet. We record the date of the assay and the operator identification. Who did the test? I think it's important to do this because it may help to identify a training issue if we've got a problem with assays failing or perhaps quality control materials not giving the appropriate result. Then we can look back and say, well, actually, this is the person who did it, and it might identify a person who needs some additional work in relation to competency and so on. So I think it's important to record that information. So I'm going to record on here some of the information that we've used. So, which is the standard, which is the lot number of this, the date, my name, the APTT reagent batch number, and the deficient plasma batch number, all of which will change from time to time. We can use this also to record which of the dilutions that we've used. These may not always be the same for reasons we'll discuss. these first three dilutions are standard, 1 in 10, 1 in 20, 1 in 40. And the 3 clotting times. So that will allow us to construct an initial calibration curve. So we need to include an internal quality control within the assay. It's really important that any group of patients, 1, 2, 3 patient samples being assayed, we should include alongside those patients a QC sample, an internal quality control, something that we know what is the expected level, and we use that material to confirm that the assay has been successful, it's been accurate, and that the results can be safely released for patient management purposes. Without the IQC, we really don't know that. It tells us we've reconstituted the reference material properly. It tells us that the reagents have behaved suitably. It tells us that there's been a successful assay. So it's really important to include an internal quality control. Very frequently, this is a freeze-dried material, a commercial material, and that's perfectly acceptable, but these work extremely well. It's also possible to prepare locally an internal quality control sample for factor VIII assays. Actually, that's what we do in my centre. And we do that for several reasons. The most obvious might be cost. It's cheaper. But actually, it's not even the main reason. The main reason is that we're able to prepare a control which is quite close in its properties to patient samples. What do I mean? Patient samples are not freeze-dried. They're either a fresh sample which has not been frozen. That will be the case if we make the assay within 4 hours interval between collection and testing. The sample's not been frozen. Sometimes the sample has been frozen if we want to take advantage of efficiencies of assaying several samples together, particularly for diagnostic samples, that might be fine. And we know we've shown for our own method that the process of freeze and thaw introduces no changes in the level of factor VIII, provided, of course, we use appropriate storage conditions. And that really means sufficiently cold. We noticed that the majority of -20 freezers really aren't adequate for storing frozen samples for factor VIII assays, particularly if those are domestic grade freezers. Tempting to use these in the lab, much cheaper than laboratory grade freezers, but they very frequently don't maintain the temperature even at -20. There may be, for example, auto defrost cycles that raises the temperature. You can get partial thawing of samples. That can introduce important differences. So we really need to be sure the samples are stored at a low enough temperature, -35, -50, -70, -80, even liquid nitrogen, -200. All of that, they're all fine, but not -20. So an advantage to a frozen sample for a quality control, we've not changed the properties so much. Freeze drying has the potential to introduce differences. We can change pH and so on, and it's necessary to take steps to prevent that. We don't need to do that in a frozen sample in the same way. The other advantage of a locally prepared internal quality control, a frozen material, to some extent we can select a particular level of factor VIII. And we do a simple thing in my centre. We use fresh frozen plasma. And you're probably well aware that the ratio of anticoagulant to plasma is a little different. It's a little bit more dilute in fresh frozen plasma than is the case in citrate of blood. So it's a little bit more dilute. It means that the factor VIII level in fresh frozen plasma, on average, is at the lower end of the reference range. So typically, if you make a small pool of a number of fresh frozen plasma bags, you might have a factor VIII level in the 50, 60, 70 international units per deciliter range. And we think that's a particularly useful level for a control, keeping in mind that one of the critical levels for diagnosis or for treatment monitoring infusions, would be 50 IU per deciliter. Below this will be time to think about further infusions in a treatment situation, and of course below this increases the likelihood of von Willebrand's and haemophilia and so on. So we think that's an important level for a control in the 50 to 70 range. So we have here an internal quality control sample, and we should treat this now very much the same as the standard material. So same plastic tubes, the same volumes of diluent, the same diluent, Auren's buffer. 900 microlitres, 0.9 of a mil, 1.9 mils, 3.9 mils. And we're going to add 100 microlitres to each of those. So 3 dilutions of the control, just in the same way that we made 3 dilutions of the calibration for the initial calibration curve that we'll talk more about later. So 3 dilutions means, of course, 3 different concentrations, each one containing progressively less factor VIII. Therefore, when we add this to the factor VIII deficient plasma, important to mix, when we add this to the factor VIII deficient plasma, we'll be adding different concentrations of factor VIII. To get good mixing in the larger volume, it's useful to make a tilt. So 3 different dilutions. 3 glass tubes, same glass tubes as the standard. We're always trying to treat QC and patient samples in the same way, as close as possible to the calibration material, the standard. Same processing, same conditions. So we should add the reagents and so on in the same order. So first, 3 tubes, 100 microlitres factor VIII deficient plasma from the same pool of factor VIII deficient plasma that we used for the calibration curve. Simply warming up at the moment. Fresh pipette tip for each operation. 100 microlitres, 0.1 mil, 1 in 10 dilution. First tube. One in 20 dilution. Second tube. 1 in 40 dilution. Third tube. And mix. In some centres, we noticed from surveys of practice that the quality control material is not assayed at 3 dilutions, but just using a single dilution. I think this is not good practice. And for the reasons that we'll discuss in a moment related to the patient sample, it's really important to do 3 dilutions of the patient samples. And I think in principle, the QC should always be treated in the same way as the patient sample. Then whichever are the conditions that apply will apply equally to both. It's really important to do this. 3 dilutions of patient sample. We need this for several reasons, some of which we'll discuss when we come to the calculations and the plotting of results. We need this to be sure that we meet 2 critical criteria that confirms this is a valid assay. When we look at the relationship between clotting times and concentration, dilution, it should be a straight line relationship. And we can only establish that if we have done several dilutions. If we do 1 or 2 dilutions and we draw a line between, you know that a line between 2 points is always a straight line. So it gives us no information. We need to have 3 in order to confirm this criteria is met. And the second, which again we'll look at when we come to the calculations, the second important criteria for a valid assay, the dose response line for QCs and for patients. These should be parallel to the dose response line for the calibration or standard. Without that parallelism, we have no evidence that the 2 materials are behaving in the same way. Actually, we know if they're not parallel, they're behaving in different ways, and we lose that criteria of a valid assay. So these samples are now to temperature. So we will now add APTT reagent to the first tube, 100 microlitres, and mix. Start the stopwatch. 3-minute activation. Second tube, different dilution, different concentration, 15 seconds, and mix. Third tube, APTT reagent, 30 seconds, and mix. Okay, so we know that these tests can be performed with a whole series of different APTT reagents, the same ones that might be used for APTT determination, obviously. And we know that these reagents contain very different phospholipid concentrations. So is that important? Well, it can have an important influence on the results here. Reagents which contain a high concentration of phospholipid are much more likely to be high phospholipid, more likely to be unaffected by lupus anticoagulant, antibodies which block the phospholipid sites where clotting factors are assembled and complexes are assembled. Although the lupus anticoagulant was traditionally described as anti-phospholipid, we now know the mechanisms more clearly. Of course, it's an antibody against the proteins which bind to phospholipid, and some of these antibodies are very different. It's an extremely heterogeneous group. But we know that interference and impact on APTT very much depends on the patients with lupus anticoagulant, but also on the APTT reagent. So there's a big advantage just now if we make the factor VIII assay with an APTT reagent unaffected by lupus anticoagulant, insensitive to lupus anticoagulant. If we do that, we take away this interfering effect. And that can have an important impact on the accuracy and on the precision, but particularly the accuracy of the result. We'll come back to that point when we look at some calculations. So if we use a sensitive reagent, a reagent with a low phospholipid concentration, then we permit much more easily interference from lupus anticoagulant, and that can cause us significant difficulties in the assay. We're running our tests just now in the water bath. Of course, the majority of factor VIII assays worldwide are currently performed on automated systems. And there are many advantages to this. Automated systems usually are a little bit more precise, a little bit more consistent. It's possible to process samples more quickly, so there is less opportunity for change in the reagent system. So there's a number of advantages. And many of these also will allow automated calculation, and that's also an advantage. So now at 3 minutes, calcium to the first tube, start the stopwatch, and mix. 15 seconds, 3 minutes, 15 seconds. Calcium to the second tube, start a second stopwatch, and mix. "30 seconds, 3 minutes and 30 seconds. Calcium to the third tube, start the stopwatch, and mix. So now the clotting is occurring once we've added the calcium. So now we need to again start the observation. The same regular tilting 3 times every 5 seconds through 90 degrees. And remember, this is the quality control sample. First tube clotted. Second tube clotted. Third tube clotted. Excuse me. So 1 in 10, 1 in 20, 1 in 40 dilution. 1 in 10 dilution, 67 seconds. 1 in 20 dilution, 73 seconds, 73.4 seconds. Third tube, 86 seconds. So we've done the standard, we've done the internal quality control. We need to now test the patient samples. So for each patient sample, 3 glass tubes into the water bath, the same pool of factor VIII deficient plasma, 100 microliters each tube. This is simply coming up to temperature. Fresh tip. Patient sample, 3 dilutions, really important. Every guideline which tackles factor VIII assays, WFH laboratory manual, CLSI guidelines, national guidelines, common theme, every guideline related to factor VIII that I'm aware of recommends testing patient samples at least 3 dilutions. I think 3 is perfectly adequate. I don't think anything is gained by testing 4 or 5. 3 is enough in my opinion, but important to test 3. I have here 3 dilutions of the first test sample. 0.1 plus 0.9, 0.1 plus 1.9, 0.1 plus 3.9. Make the dilutions into the test. 1 in 10 dilution, first tube, fresh pipette tip. 1 in 20 dilution, next tube, fresh pipette tip. 1 in 40 dilution, third tube. Warming to 37. So why 3 test dilutions? 2 reasons. One relates to the precision. There are several publications which have looked at the precision of factor VIII assay results and shown that there is much better precision, much closer agreement between results obtained in different centres is much better if in centres who use 3 test plasma dilutions. So for example, we ran a survey through our proficiency testing programme and we asked people, how many dilutions do you use in your factor VIII assay? I'm going to start the activation whilst we're talking. APTT reagent, first tube, and mix. Second tube at 15 seconds, and mix. Third tube. And mix. So we asked our centres, when you make a factor VIII assay, how many test plasma dilutions? And we sent them the same test sample for factor VIII assays. And when they sent the results back, so they all assayed the same control material, we divided the results according to whether the centre did 3 dilutions, 2 dilution, single dilution. The average result was very similar, but the variability was significantly worse in the centres doing a single test dilution. Actually, the CV, the coefficient of variation of results in different centres, was fairly close to 100%. It was enormously variable. Single centre, single test dilution. If you looked at the centres who did 2 test dilutions, there was a much better precision, much closer agreement between results in different centres, and not surprisingly, I think, the best agreement occurred in those centres who did 3 test dilutions. So, important for precision. There's an even more important reason for doing 3 dilutions. It absolutely improves the accuracy in the presence of interfering substances. The most common interfering substance, lupus anticoagulant. Majority of APTT reagents, which are used in factor VIII assays, the majority are affected by the presence of lupus anticoagulant. And if you do the first test dilution, in this case 1 in 10, this is a higher concentration of antibody present compared to the 1 in 20, where there's obviously a lower concentration of antibody, even to the 1 in 40, a lower concentration still. And people have shown very clearly that in the dilution with more antibody present, there's more interference. So the clotting time is falsely prolonged to a greater extent, leading to underestimation of the activity. So you produce an inaccurate result. And you only know about this impact if you've tested additional second and third dilutions where the effective inhibitor is progressively lost, and you get closer and closer to the truth, closer to the real concentration, closer to an accurate answer. So the degree of inaccuracy is much, much worse, and there is the potential to seriously underestimate the real concentration and to falsely label a patient. So for assays which are performed with APTT reagents sensitive to lupus anticoagulant, it's really, really important. If the assay is performed with a reagent largely unaffected by lupus anticoagulant, then there still can be other interfering substances which cause this problem. So 3 minutes, calcium. For example, anticoagulants, like heparin, like the new direct oral anticoagulants, rivaroxaban, apixaban, dabigatran. All of these can cause interference and a similar effect, falsely prolonging clotting times, leading to potential for serious underestimation of the real concentration. And this is apparent only if you test multiple dilutions, 3 dilutions, so that you can see this non-parallel effect that we'll come back to when we look at some plotted results. So I think that it's a good recommendation in my opinion, and that's the reason why it's a consistent recommendation in all of the guidelines written in this area to the best of my knowledge. It's certainly there in the WFH lab manual, and I'm confident we'll retain it in any future editions. If you ask the centres who do a single test dilution, why do you do this? The most frequent reason that's given relates to cost. People say, but I don't want to spend the extra money on those extra dilutions, extra reagents. But I have to say, I think it's a false economy, because the financial implications of an imprecise or especially an inaccurate assay could be significant in terms of inappropriate use of blood products, concentrates, for example, I should say, which are, of course, extremely expensive compared to the cost of the laboratory assay. So I think investing a small amount of additional cost in the lab assay really pays back when it comes to the overall cost of the healthcare for that patient. I think it's a false economy, in my opinion. The difficulty sometimes is that the cost sits in different budgets in relation to laboratory diagnosis and testing compared to treatment budgets. This is a common problem. Okay, so the first test sample, 1 in 10, 1 in 20, 1 in 40. 81.5 seconds, 89.5 seconds, 104 seconds. So already you can see longer times than what we've seen for the standard. Longer times, lower concentrations. So the second patient sample is underway, 100 microlitres of deficient plasma, each of 3 tubes, 1 in 10 dilution of test sample, first tube, 1 in 20, second tube, 1 in 40, third tube, and these are incubating. In a moment, when we reach the 3 minutes, we'll add the calcium. So if you think a little bit about the sample which is collected for factor VIII assays, we know that a number of different blood collection tubes are in use, and we also know that this can have an impact on results of APTT tests. So since these are APTT reagents we're using in a one-stage factor VIII, there's a potential at least for different results to be obtained with different reagents. Does the tube collection system, does that impact on the results? Actually, the data that's available suggests that results are interchangeable. Samples collected into the currently available commercial tubes will get the same result of factor VIII assays. So probably the tube is not having an important impact on the results which we obtain. Of course, it's important that the tube is properly filled and safely handled. If we get hemolysis during the collection and processing, 3 minutes, calcium, if we get hemolysis during the collection and processing, then this can affect the results of APTT and may also have an impact on the results of factor VIII assays. Hemolysis in the sample, artifactual hemolysis, that can lead to activation of clotting factors. We may have enzymes present. We may have some activated factor VIII generated in the sample. And this can affect the results. It can influence the degree of parallelism between the dose-response curve for patient compared to the standard. These may not be parallel where active clotting factors are present. So that's another reason why 3 dilutions can be really useful, so we can assess this. Probably the most important pre-analytical variable in relation to factor VIII would be storage of the sample if it's deep frozen. And I already mentioned we absolutely should avoid storage at -20, particularly in domestic grade -20s. Just waiting for the third tube, third dilution, and it's gone. So we've got clots now in all three dilutions. Progressively longer times, more diluted, progressively lower concentrations of factor VIII. Clotting times on test number 2. First dilution, 67 seconds. Second dilution, 70 seconds. Third dilution, 78 seconds. 1 in 10, 1 in 20, 1 in 40. So we've done a third patient, 3 dilutions, 0.1 of deficient plasma, 0.1 of 1 in 10, 1 in 20, 1 in 40. And the clotting times for the third patient, the first dilution, 141 seconds. The second dilution, 141 seconds. The third dilution, actually 142 seconds. So actually very close. Doesn't always work out so close, but nevertheless, the same clotting time in each of the 3 tubes. So what does that mean? It means that we've not got a differentiation. It means that the level of factor VIII in those tubes is below the level that would have an impact on the clotting time. What does that mean? Well, we know a factor VIII deficient plasma which completely lacks factor VIII with absolutely none present, no genetic capability to synthesize factor VIII, but we know a sample from such a patient, we still obtain a clotting time, at least in the APTT. And that's because of the artificial nature of the reagents. We're running these reactions here in a very artificial way. Remember, in the APTT reagent, we're activating with kaolin or sealite. These are not physiological activators. Kaolin, clay particles, sealite, effectively sand, ellagic acid, not physiological activators. We're running these reactions very quickly in a very artificial way, and under those conditions, we obtain clotting times, even in the absence of factor VIII, so a severe haemophiliac APTT. Incoagulable? No. Does it clot? Yes. 90, 100, 110 seconds maybe. And it's the same here with this factor VIII deficient plasma. We will obtain a clotting time, and that's what we've done. So at this moment, for that patient, 140, 140, 140, we don't know what the level might be, and we'll look at this when we make the plot. Just now, I'm running a new calibration, a second standard curve. It's the same reference plasma, 3 new dilutions, 1 in 10, 1 in 20, 1 in 40. Prepared these dilutions afresh with new tubes, a new buffer. And I'm running this at the end of all the patients. So as we get to 3 minutes, calcium to the first, 1 in 10. 15 seconds later, 1 in 20, and mix in the third tube. So during the assay, the very first sample we tested, reference plasma, calibration plasma, and the very last is a repeat of the same reference plasma. New dilutions, but the same reference. So what's the purpose? We need to know if any of the conditions have changed during the assay. Whilst I'm talking, whilst I'm pipetting, have I introduced contamination between any of the reagents? Has the water bath stopped working during that time? Have I turned it off by mistake? There could be changes during the period of the assay. And if we run a standard at the end, because we run a standard at the end, as long as those clotting times are very similar to the clotting times at the beginning, we can safely assume that the assay conditions have stayed constant during the time of that assay. We don't expect to see identical clotting times, but we hope to see very similar clotting times at the end. And it's an important question in order to confirm the validity of the assay. If we were running this assay on an autoanalyzer, in which the test and standard are analysed at the same time, then it's not so important because we don't see the same opportunity for drift in the assay system, for change in the reagents. If there's a delay in the time, and there is for most analyzers, then we should also then finish with a repeat calibration in the same way that we began the assay with a calibration curve. So this is a repeat of the standard that we began with. Again, 1 in 10 dilution, 1 in 20 dilution, 1 in 40 dilution. And the 1 in 10 dilution at the end, 64 seconds. If you remember at the beginning, 63. The 1 in 20 dilution, 70 seconds. At the beginning, 69. The 1 in 40 dilution, at the end, 78.5 seconds. Now the one at the beginning was 85. So that's really quite a different clotting time. So we have to ask ourselves, how much of a difference do we accept? And we really need the standard at the end. If it were plotted as though it were a patient, it should be within 10% of the standard at the beginning. The clotting times should be very close. So 64, 63, that's an acceptable difference. 69, 70, also an acceptable difference. 78.5, 85, that's not an acceptable difference. Something is wrong with one of those clotting times, and we'll know which when we come to the graph paper to make the calculation. Something's gone wrong somewhere in one of those tubes. And it's sort of known for that to happen when we're running a test manually in this way. It's another reason why we make a calibration curve at the beginning and at the end. So we've got, because there is a close agreement between two of the clotting times at the end and the beginning, we can take an average of those 4 clotting times, and we'll know from the graph paper which of the other 2 is more likely to be the correct time. So I think it's really important to do this. There is one more piece of information we need, and that relates to, helps us interpret the results in the patient sample where we obtained very long clotting times. 140 seconds, 141, 142, very similar clotting times in 3 different dilutions. So what we need to know is, what would be the clotting time of this assay system if we didn't add any factor VIII? That's an important piece of information. And how do we obtain that information? We start with the same factor VIII deficient plasma, 100 microlitres. Just a single tube. And remember, for all the previous tests, we made 3 dilutions, dilutions of test, standard, QC. And we added that to the 0% factor VIII, the factor VIII deficient plasma. To look at the clotting time for this assay system in the absence of any added factor VIII, we simply add the dilution buffer now to the factor VIII deficient plasma. So I need the same buffer we've been using to construct dilutions, and this is added to the factor VIII deficient plasma, 100 microlitres. So it's in place of the dilution. No factor VIII in the buffer, of course. So there's just deficient plasma and buffer. This is warmed, and then we treat it in the same way as we did the dilutions of test, standard, QC, and so on. Coming up to temperature. Incubated for 3 minutes. So we've got the factor VIII deficient plasma. Contains contact factors, other clotting factors, but completely lacks factor VIII. We know that it clots for the reasons we've already discussed. We'll obtain a clotting time for a sample which completely lacks factor VIII. So just here we want to know what will be that clotting time in the absence of any added factor VIII. And when we get that piece of information, we can use that to assist interpretation of the clotting times from patient mixtures. Any patient mixtures with clotting times very similar to this clotting time for buffer alone, sometimes called blank time, sometimes called buffer time. Any patient mixtures with clotting times similar to this don't have sufficient factor VIII in to have any impact on the dose-response curve. And if the clotting times are similar, they almost certainly contain a very similar level of factor VIII to the buffer. In other words, no factor VIII. So it's a really useful piece of information that allows us to say any clotting times around this, such a patient sample is probably lacking any factor VIII. We need the graph paper and the plot to really draw a safe conclusion on that, because of course we made some dilution of patient samples. But of course we often have some information in advance of beginning the factor VIII assay. We often have some information about the anticipated levels of factor VIII. We may have past results on the same patient. We may know this is a family with severe haemophilia. This is a patient with severe haemophilia without recent treatment. So we often have some indication in advance of what we might expect. And if we anticipate a very low level of factor VIII, 5, 4, 3, 2, 1, less than 1 international units per deciliter, so moderate or severe haemophilia, if we anticipate that before we start the assay, we can take that into account. We should take that into account before we construct the dilutions. And if here there's two things we can do, two things we should do. The calibration curve that we've generated so far, 1 in 10, 1 in 20, 1 in 40. The first thing we can do is extend that calibration curve, include some additional dilutions, 1 in 80, 1 in 160, of course with significantly lower levels of factor VIII, taking the concentration in those dilutions down lower towards the level that might be expected in the patient sample. So that's one action we can perform. The second is we can modify the dilutions of patient sample. So instead of 1 in 10, 20, 40, we might choose instead, where we expect a very low level, 1 in 5, 1 in 10, 1 in 20. 3 minutes, calcium to this buffer blank tube. If we anticipate a rather high level of factor VIII, again we may have some clue about that before we undertake the assay. Perhaps a mild von Willebrand's patient who's been treated with DDAVP, maybe a mild haemophiliac who's been treated with DDAVP. Perhaps we've got an APTT that's particularly short. If we do still want to make an accurate factor VIII concentration assay in such a patient, we can also take that into account when we construct our patient dilutions. So if we anticipate a rather high level, or perhaps we've done the factor VIII assay that indicates a high level, if we need an accurate answer, and we may do, then we should make higher dilutions. So we might test such a sample instead of 1 in 10, 20, 40, we might do 1 in 20, 40, 80. We might do 1 in 40, 80, 160, for example. So the aim would be to produce, where possible, clotting times on the test and QC materials, clotting times which sit, where possible, within the range covered by the standard. And those of you who are running factor VIII assays on commercial large autoanalyzers, you will, I imagine, many of you will use additional concentrations, additional dilutions to construct the standard curve. And sometimes it's necessary to produce different calibration curves to deal with samples with particularly low levels, for example. On other systems, it is possible to use a single curve that's suitable for all the expected levels. So we have some discussion about that in the WFH laboratory manual. We have a section in there related to automation. And again, I have some comments on that in the section on factor VIII assays, and I would refer you to that. So remember, this is deficient plasma, simply with buffer added, followed by APTT reagent and calcium. And we're looking for a clotting time. Aha. And we have a clot. It's a particularly prolonged clotting time, well, 142 seconds. And when it's particularly prolonged, as in this case, the clot is rather weak. It's rather wispy. And that can sometimes cause problems on autoanalyzers, but I think with experience it's possible to recognize that this is indeed a clot during the manual method. So 142 seconds. Now, and if you remember, that's very similar, almost identical to the times we obtained in one of the patients at different dilutions. So those clotting times are very similar to the blank time. Indication being that there is very, very low level, probably no factor VIII present in that patient sample. Once we've obtained the clotting times in the factor VIII assay, we need to make some decisions about the data before we can even move to the plotting process. The most important question relates to the clotting times we've obtained with the standard calibration reference plasma. Remember that we did this at the beginning and again at the end of the assay, so that all of the patient and IQC data were generated in between, sandwiched between those two sets of calibration plasma data. So we need to look at the clotting times we obtained. For the 1 in 10 dilution, at the beginning of the assay, 63 seconds. When we repeated the standard at the end of the assay, 1 in 10 dilution, 64 seconds. Not identical, that's typical, but a very similar result, an acceptable variability, the same answer. For the 1 in 20 dilution, beginning of the assay, 69 seconds. End of the assay, 70 seconds. Once again, very similar, acceptable variation. The 1 in 40 dilution at the beginning of the assay, 85 seconds. For the calibration curve we ran at the end of the assay, the 1 in 40 dilution, 78.5. So that's quite different, 7 seconds. That's a bigger difference, almost 10%. Normally we would expect the clotting times to be within 5%. So that's quite a difference. So at this point, it's possible that one of those includes some error, some imprecision, and we'll be able to reach a judgment on that when we take those clotting times onto the graph paper, which is the next step. The graph paper we're using just now for the calculation for the one-stage factor VIII, this is double logarithmic. It's acceptable to use log linear paper. This also normally gives a straight line relationship for the calibration curve. So either can be used. We're using log just now. We noticed for the reagents that we've been using for this demonstration, this normally gives a better line using this graph paper. So we're working on double logarithmic scale. We plot the concentration of factor VIII along the x-axis, the clotting time in seconds on the y-axis. If we decide the first one is 10 seconds, these become 20, 30, 40, 50, 60, 70, 80, 90, 100 seconds, 200, 300, 400. So 10 seconds, 100 seconds, 200 seconds. Plotting time. Concentration. This we will derive from the dilutions. Whichever is the first dilution, in this case 1 in 10. Perhaps with another reagent set it might be 1 in 5, with even a different reagent set it might be 1 in 20. On this occasion the first dilution 1 in 10. For the purposes of plotting, it's conventional to take the first dilution, in this case 1 in 10, and use that as a 100% for the purposes of plotting. Logarithmic scale. If this is 100%, 90, 80, 70, 60, 50, 40, 30, 20, 10%, 9, 8, 7, 1% for the purposes of plotting. First dilution, 1 in 10, which we're considering 100% for the purposes of plotting. So the clotting times we obtain for the 1 in 10 are on this location. Which was the clotting time for the standard 1 in 10 dilution? 63 seconds, 64 seconds. Very close, so we should take an average, 63.5 seconds. So we need to locate on the vertical axis, where is 63.5 seconds? 10 seconds, 20, 30, 40, 50, 60, 70. It sits here between 60 and 70, very close to the 64 point on this axis. It's a very narrow scale, and this is a problem with manual calculations in this way. we can introduce some variability. If several people take the same clotting times to the graph paper, there is some variability in the way the figures are interpreted. So we have to keep that in mind as a source of variability. 63.5. Now we need the clotting times for the second dilution. The second dilution, 1 in 20. Where do we plot this? The first dilution, 1 in 10. The second dilution, 1 in 20. So the concentration in the second dilution is 10 over 20, 50% of the standard. It's 10 over 20 times 100, 50%. So we go along the bottom, 100, 90, 80, 70, 60, 50%. So the 1 in 20 dilutions will be plotted in this area. So for the standard, 1 in 20 dilution, 69 seconds, 70 seconds. Very close. Take an average, 69.5. 1 in 20 dilution, 50% line, 60, 2, 4, 6, 8, 69.5. Of course, it's very just beneath the 70. Third dilution of standard, 1 in 40. What's the concentration relative to the first dilution? 10 over 40 times 100, 25%, 50%, 40%, 30%, 20. How many gradations between 20 and 30? There are 10. 20, 21, 22, 23, 24, 25%, 1 in 40 dilution. Clotting times for the standard. These were the two, if you recall, a little different. 85, 78.5. They're a little different. So at this point, we have to ask the question, is one affected by some pipetting error, by a technical error during the test? So I want to look at both of those times to see where they sit on the graph paper. This is the 1 in 40 dilution, 25%, 78.5 seconds. So 70, 72, 74, 76, 78.5 could be here. On the other hand, the other 1 in 40 clotting time, 85 seconds. 80, 82, 84, 85. So we have a decision to make. And for this we now need to look, is there a straight line relationship? And that's where we need the ruler. So when this plot is made manually in this way, on graph paper, this is done visually. Of course, on an autoanalyzer, this is done automatically by the software, and on most autoanalyzers there are assessments of linearity, and this is a useful measure, and there's an advantage to run such assays for that reason on autoanalyzers. Nevertheless, the technique that we've used is precise enough for patient management purposes and can be used. So we need to see, do we have a straight line relationship? And it's immediately apparent that there is a very good straight line relationship, at least if we use the clotting time of 78.5 and ignore the 85. It seems as though this is an outlier. If we put the line of best fit using the ruler and through those points, is it a straight line relationship? Yes. Is every point exactly on the line? No, it's not, and that's typical of this type of assay. I think there's an error in the 85 seconds. 5 of the 6 clotting times, taken together, form a good straight line relationship. I think that's sufficient. If these were patient samples for patient management purposes, I would be, at this stage, saying I think it's safe to proceed to make calculations next on the IQC material. So I think the error, whatever it is, has occurred with the 85 seconds. We've met the first criteria. The standard gives a straight line relationship. Now we have to ask the question next, what about the IQC sample? 1 in 10 dilution, which we're treating as 100%. So this is plotted on the same line as the 1 in 10 dilution of standard, of course. Clotting time, 67 seconds. 60, 62, 64, 66, 67 seconds. 1 in 20 dilution. Again, plotted in the same line. 10 over 20 times 100, 50%, 50% line. 73.4 seconds, just under the 74-second gradation. 1 in 40 dilution, IQC sample, 86 seconds. So 1 in 40 in the same plane, 86 seconds. So now we have to ask a question for the IQC sample. Do the 3 lines, do the 3 points, do they form a straight line relationship? And is that straight line parallel to the standard? These are the 2 important criteria for a valid assay that means it's safe to compare, in this case the IQC, with the reference material. Is it a straight line? Is it parallel to the standard? So we now need the best straight line, and the question, is that parallel to the standard? Is it a straight line? Yes. Is it parallel to the standard? Yes. Is every point exactly on the line of best fit? I don't think so, but very close. And again, this is a feature of the assay that even a very small difference, 1 or 2 seconds, can start to move this line substantially in terms of the location on the graph paper. So we need to take some care in the plotting. So this is the IQC sample. Straight line, parallel to the standard. Now we need to make a comparison of the relative concentration. What is the concentration in the IQC relative to the reference or standard line? How do we do that? We look for the point where the straight line through IQC material, we'll look for the point where this cuts through the 100% line. Of course, it's on or close to that clotting time if the assay has been successful. It may not be exactly on that clotting time, but it's normally, of course, very close to it because we've got a straight line and parallel relationship. So we need to know which is the clotting time here where the IQC line cuts 100%. And in this case, 62.46, around that 67 seconds. And then we ask a question, which is the concentration of the standard which would have clotted in 67 seconds? And the simple way to ask that question is to take a horizontal line from this point where it cuts to 100% and look where does that clotting time occur on the calibration line, and that's here. And then we drop a perpendicular and ask the question, what's the concentration of standard which would have given that clotting time? 100%, 90%, 80%, 70%. How many gradations between 70 and 80? 72, 74. So the concentration of the standard which would have clotted at that clotting time, 74%. It means the concentration in the IQC is 74% of whatever is the concentration in the reference. So this has not yet been corrected. This is an uncorrected figure, 74%. It's uncorrected yet. It's not been corrected yet for the concentration of factor VIII contained in the reference plasma. Remember, the reference plasma is usually somewhere close to 100 international units per deciliter. It's usually a pooled normal plasma, but it's very rarely exactly 100 international units per deciliter. It has an assigned potency, maybe 90, maybe 100, maybe 110. It has an assigned potency which has been derived experimentally when that calibration plasma was assayed against an international standard in a series of experiments, a series of assays exactly like the one we've just done. That's how the potency is assigned. So we now need to know what is the potency of factor VIII in the reference plasma we've used to construct this assay and this line. The particular reference plasma that we used had an assigned potency of 94 international units per deciliter. It's a pooled normal plasma. It's close to 100, but not exactly 100. 94 international units per deciliter. The concentration of factor VIII in the IQC material is 74% of 94, 69.6, 70 international units per deciliter. What is the expected concentration of the factor VIII in this sample? We need to look at the target values for this particular QC, and we need to know that this value sits within the target. The target range for this particular lot number of QC, 64 to 74. Is 70 within that range? Yes. It means that the assay has been successful. It means that we can proceed to calculations of patient results and that these will be safe to release for patient management purposes. So we need to plot the patient results. Patient number 1, 1 in 10 dilution. On the 100% line, clotting time 81.5 seconds. Here. 1 in 20 dilution. 89.5 seconds. Here. 1 in 40 dilution. 104 seconds. So we now have the 3 points for the first patient sample. Is it a straight line? Yes, pretty close. A straight line parallel to the standard. We put the line of best fit, done visually. It's a straight line relationship. It's parallel to the standard. It meets the criteria for a valid assay. Are the clotting times exactly on the line? No. This is perhaps a second above. This may be a second below. And this is typical. But overall, straight line, parallel to the standard. Where does the line intersect the 100%? It does so at a clotting time around 82 seconds. Which is the concentration of standard? Where is 82 seconds? Here. We drop a perpendicular from 82. 20%. The concentration of this sample, test sample number 1, is 20% of the reference or calibration plasma. So not yet corrected, 20%. What's the level of factor VIII? 20% of 94 international units per deciliter. So that's 19 international units per deciliter. This was a patient with mild haemophilia A patient with an elevated APTT. It was around 8 to 10 seconds prolonged compared to the upper limit of reference range. Next patient, 1 in 10 dilution, 67 seconds. 1 in 20 dilution, 70 seconds. Here. 1 in 40 dilution, 78 seconds. Here. So now we have 3 points. It is a straight line, but it's not parallel to the standard. Here is above, and here on or below the line. Straight line relationship, not parallel to the standard. So we have not met the criteria for a valid assay. This sample is a patient who has lupus anticoagulant. The APTT reagents we've used for this factor VIII assay contains a low concentration of phospholipid. It's sensitive to, it's affected by the presence of lupus anticoagulant. So what's happening here? In the 1 in 10 dilution, the antibody is able to prolong the clotting time a false prolongation. It elevates the clotting time by removing some of the phospholipid sites for the reactions. The reactions run slower, the clotting time is falsely prolonged. So we get a false elevation. As we progressively dilute, 1 in 20, 1 in 40, it's a feature of lupus anticoagulants that we begin to lose that inhibitory effect, and the false prolongation is less prevalent at these higher dilutions. So we move in the higher dilutions closer and closer to the truth, to the real answer, to a clotting time unaffected by this interference. The maximum interference is in the least diluted sample, the 1 in 10. So this does not meet the criteria for a valid assay. So it's not possible to give a fully accurate estimate of the factor VIII concentration. But what we do know is that the higher dilutions will move closer and closer to the truth, closer to the real answer. And if we can obtain 2 dilutions, which would give a straight line that's parallel, crucially, which is parallel to the standard, that's an indication that we've diluted away the inhibitory effect. And if that occurs, then I think it's safe to use those 2 dilutions to make an estimate of the factor VIII activity. In this case, we've got false prolongation with the first dilution. But the other 2 sit almost exactly on the calibration line. Just double checking the clotting times. Yeah, almost practically exactly on the calibration line. And therefore, both giving a straight line parallel to the standard. So from those 2, we could conclude that actually the concentration drawing the straight line is 100% of the concentration in the reference material, 100% of 94 international units per deciliter. So we didn't meet all the criteria for a valid assay. There is interference. I think we're safe because these 2 show a straight line parallel to the standard, and it's clear that this has a normal concentration of factor VIII. Just keep in mind, why would we be doing a factor VIII assay in a patient that turns out to have lupus anticoagulant? It may be because, most frequently would be because we've seen a prolonged APTT and we want to be reassured that it's not caused by mild haemophilia or mild von Willebrand's disease, perhaps prior to surgery or for some other reason. It's also, I think, an illustration of why we must be really careful in our assay design and why we should not use a single test dilution. Let's suppose we'd made just a single test dilution, the 1 in 10. That would be the normal practice in centres doing a single test dilution. Remember, the clotted time was 67 seconds. If we only had that point and we looked on the standard line, what is the concentration of standard that would plot in 67 seconds? The answer would have been around 74%. 74% of 94, 69.6, 70 international units per deciliter. We would have underestimated the real factor VIII by about 30%, by about 25, 24 international units per deciliter. That's an important inaccuracy. And sometimes that effect is much more marked. We can see falsely reduced levels in the first dilution. So I think it's absolutely the reason why we've got to use 3 dilutions. Turning now to the 3rd patient sample. The 1 in 10 dilution, 141 seconds. The 1 in 20 dilution, also 141 seconds. The 1 in 40 dilution, 142 seconds. First question, is it a straight line? Actually, it's a pretty straight line. Is it parallel to the standard? Absolutely not. There's no differentiation in clotting times at the 3 different dilutions. And now we have a problem. The clotting times are very far outside the range that we've obtained in constructing the calibration curve, which only went up to 78, 79 seconds. So we've got several options. We could go back and repeat the assay and extend the calibration curve to include 1 in 80, 1 in 160, higher dilutions, much longer clotting times, of course, and this would extend the calibration curve so that we could be confident about the linearity of the calibration curve at those lower levels. But we can also draw some information from the fact that we've seen no differentiation in the clotting times from these 3 dilutions. And we also need to remember, what was the blank time? What was the clotting time of buffer alone in this assay system? And that was also 142 seconds. So this patient in these dilutions is giving very similar clotting times to the clotting time of buffer alone. It's highly likely this patient has no factor VIII. And of course, we may have some other information that this was a patient who we know from previous history has severe haemophilia, and it's a patient who developed inhibitor secondary to replacement therapy. So with that information, we've got confirmation here that actually there's no factor VIII present in this patient's plasma. In this case, it's not a surprise. Sometimes, of course, we don't have that information. But if we look again at the calibration curve, if this were extrapolated, and in particular if we had those additional dilutions to confirm the linearity, sometimes it's not present, but it may be, then we know, we can see that the clotting time here would disappear off scale in this opposite direction. And remember, 100%, 10%, 1%. It will intersect the axis substantially below the 1% point. So from putting all that information together, the level of factor VIII in this sample, less than 1 international unit per deciliter. Lupus anticoagulant is the most common cause of this problem of non-parallelism between the patient line and the standard, but there are others. We can see a similar effect if we're working in one-stage assays where other antibodies are present, other inhibitors are present. For example, if we were running a one-stage factor IX assay in a sample from a patient with a high titer anti-factor VIII antibody, this can also show similar non-parallelism. Another occasion, returning to factor VIII assays, if we have a badly collected sample in which there is activation, presence of enzymes, the clotting process is underway before we begin the one-stage factor VIII, then in such a sample, the presence of 10A, activated VIII, for example, this can also lead to non-parallelism. And in this case, we see divergence, so that at the higher dilution, the estimate of potency gets lower rather than higher. We should, in the example we've just used, each of the patient samples were diluted using the same set of dilutions as the standard, 1 in 10, 1 in 20, 1 in 40. Sometimes that's not the case. If the patient is known to be moderate haemophilia, possibly severe haemophilia, we anticipate a low level, then in advance of constructing the assay, we can choose a different set of dilutions. In such a case, perhaps 1 in 5, 1 in 10, 1 in 20. If we know that the patient has expected to have a rather high level, perhaps based on APTT or post-treatment with DDAVP or some other information, then again we can take that into account, and we might choose to assay then at higher dilutions, 1 in 40, 1 in 80, 1 in 160. It's convenient to keep the same proportions, and this way we can plot the clotting times in the same location on the graph paper and make an allowance, a calculation for the different pre-dilution on conclusion of the calculation. So I think we can make use of the prior knowledge to construct carefully the assay design. All of the principles of what we've been discussing is all given in some detail in the sections in the WFH laboratory manual. So I hope that you'll take the chance to access that. It's on the website, as you know, available for free download, and we hope you'll take advantage of that. It's intended as a resource for your use.